Hello everybody and welcome to our discussion on the Swing Bed SNF and NF rates. SNF is for skilled nursing facility, NF is for nursing facility. So for our agenda we're going to be talking about what a swing bed actually is. Then we'll be talking about the cost report mechanics of the cost per diem calculations and the cost carve outs. Then we'll go into the important topics of where to actually find and report the swing bed skilled nursing facility, the SNF rates, and the nursing facility or the NF rates. So first of all, we need to talk about what a swing bed actually is. Now, a swing bed is used when a hospital has a patient that they need to provide services to, but they're not quite at the same level of the normal inpatient services, the hospital services. In many cases, this is just a continuing level of care needed for that patient after their initial hospital inpatient stay. So they have a couple of options. They could certainly transfer to an actual skilled nursing facility or a nursing facility if they have one, or maybe another facility they want to send it to. So we have the question of whether that hospital has a distinct part, SNF or NF, or are they treating some of their hospital beds as swing beds and having a swing bed skilled nursing facility. Now these can take place in the acute care PPS hospitals or in the critical access hospitals. Now it's especially common in a critical access hospital just because of the fact they often do not have sufficient utilization for that type of service to maintain a distinct part skilled nursing facility. But even for the acute care hospitals, this may allow for more flexibility in bed management. They don't have to have a certain set number of beds for just hospital services and then a completely separate set of beds that can only be used for skilled nursing facility services. They can use the same group of beds and they can transfer them as they need to the different levels of service. So now one important thing I wanted to talk about here is the distinction between the SNF and the NF. For our purposes on the Medicare cost report, the skilled nursing facility, the SNF, is considered Medicare, and the NF, the nursing facility, is for everything else, non-Medicare. We tend to focus on Medicaid for nursing facility, but in reality it's anything other than Medicare. And this distinction will become important in just a little bit when we talk about the mechanics and the rates themselves. So the reason we have these rates, the reason we have this cost report, these cost report sections, is that we need to find a way to carve out the costs from the hospital and apportion them to the swing bed, SNF or NF. Now the reason that we have to make the distinction between the normal hospital level of service and these swing bed services is that we want to find out what the cost is for hospital versus swing bed. The routine costs of the entire hospital and the swing bed, they're commingled. The cost report identifies total costs in general, but somehow we need to be able to separate those out between the hospital services and the swing bed services. Now, depending on the type of facility we're talking about, this serves a couple of different purposes. For the critical access hospitals, we need to be able to carve out the swing bed costs so that they can be reimbursed separately from the hospital. Now, the other thing about this, when we get into the SNF versus NF, for those nursing facility rates, those are non-Medicare, so we have to carve those out completely. We want to carve them out of the allowable reimbursable costs. But even the Medicare, the swing bed SNF costs, we still want to be able to carve those out so we can report them on a separate worksheet of the cost report. Now, for the acute care hospitals, there's not really going to be a payment difference. It's going to be data accuracy for future rate setting. So that's what that boils down to. Now, there might be some payment impact if there are various cost-based pass-through amounts reported for the acute care hospital. But in general, acute care hospitals are not reimbursed on costs like a critical access hospital is. So it's not quite as important, but it's still important for data accuracy. Now, as I said, there's that distinction, there's that difference between the acute care and the critical access hospital. For the acute care hospital, what we're going to see is that both the SNF Medicare rate and the NF Medicaid rate are important for proper cost reporting. So what we're going to see here is that the acute care swing bed SNFs, for Medicare purposes, they're actually reimbursed based on the PPS, SNF PPS, whereas the CAH is based on cost for that swing bed SNF. So for that reason, we're going to have to report this swing bed SNF Medicare rate. And this can be found, we'll see this in a little bit, but it can be found from CMS Pub 15-1, Section 2231. That rate is actually going to be used to carve that cost out, and then they're going to be reimbursed on SNF PPS on worksheet E-2. Now, the critical access hospital does not get paid at all on the PPS for the swing bed. In fact, they're actually paid based on the same cost per diem as the hospital. And again, the whole per diem calculation we'll see in just a bit. But they're reimbursed based on that same cost per diem. So what I'm saying here is, for a critical access hospital, we do not need the Medicare rate. We only need the Medicaid NF rate, nursing facility rate, for the critical access hospital. We'll see that again in just a minute. In both cases, however, worksheet E-2 is used to determine the actual cost reimbursement, the actual reimbursement for these facilities. Again, the difference is that acute care hospitals are paid based on PPS. Critical access hospitals, the swing bed there is paid based on cost. So for both types of facilities, we always need the Medicaid NF rate, the nursing facility rate, because that's used to carve out the non-Medicare cost that's not reimbursable in any form or fashion on the Medicare cost report. So now let's walk through a little bit of the cost report mechanics behind this. On worksheet D-1, we're going to see the various routine cost apportionment calculations that are needed. So what we see here, and by the way, in the next screenshot, or a couple screenshots from now, we're going to see that for routine costs, we actually have a variety of routine cost centers. But what we're talking about here, all of these next couple of slides deal with the general routine cost center versus intensive care, the burn units, the coronary care units, the other routine care cost centers. So all of the mechanics we're talking about here, including the carve-outs, are for the general routine cost centers, or the one general routine cost center. So the apportionment is basically total costs, total routine costs, divided by total days, and that gives you a total cost per day, cost per diem. Then we take that total cost per diem and we multiply that by whatever number of Medicare days have been allowed to determine the Medicare routine cost. Now, the issue with this, and again, if this is a critical access hospital, then this Medicare routine cost becomes important. That's the reimbursement. For an acute care hospital, it's just data only. But the thing about this, as part of this cost apportionment, we have to carve certain costs out. So what we're going to see here, D-1 Part 1 handles the accumulation of all of the inpatient day statistics, the different types of inpatient days, and by the way, everything is by calendar year, so before and after 12/31 of the cost reporting periods. So we have the inpatient days that include private room days, swing bed days, and it excludes newborn days. And then we have the private room days reported. We'll see where that comes into play in just a bit. We have the swing bed SNF days before and after 12/31. The swing bed NF days before and after 12/31. Down here in rows 10 through 13, they're largely the same numbers we've reported up here, 5, 6, 7, and 8, the total. The only thing is these are those days that are specific to Medicare, Title 18 only, and then for lines 12 and 13, only those NF days related to Title 5 or 19. For Medicare purposes, generally, Title 18 is Medicare. That's where these SNF days come from. So we're going to report those. Then we move on to D-1 Part 1, later on in that same part, lines 17 through 20, this is what we're mainly focusing on for this video. These are the rates themselves. So lines 17 and 18, these are swing bed SNF services. It's the Medicare rate, again, before and after 12/31. We're going to see where to get that rate from. Again, this is only for the acute care hospitals. The critical access hospitals, this should stay at 0. In fact, the cost report will reset it to 0 if you try to put something else in there. 19 and 20, these are the Medicaid rates for the swing bed NF, the nursing facility services, before and after 12/31. Again, this should be for both acutes and critical access hospitals. There is nothing in the cost reporting software that knows what this rate is. As we'll see in just a bit, this is state by state. We're going to talk about where to find that. And as I mentioned earlier, there are also some other carve-outs for unnecessary costs. D-1 Part 2, lines 20, it's really more 29 through 37, or 36 really. This carves out the costs for unnecessary private room charges. So Medicare only reimburses for a semi-private room unless there are extenuating circumstances that require that patient to be served in a private room. So there's the mechanics for that. And then this is what I was alluding to earlier. Later on in D-1 Part 2, we have the different types of routine cost centers. Intensive care, coronary care, burn, surgical intensive care unit. The apportionment for these routine cost centers is much easier. It's just the total inpatient cost for that particular cost center divided by the corresponding total days to get an average per diem, and then it multiplies it by the Medicare number of those specific days to get that amount of cost. So there are no carve-outs for these intensive care type units. All of the carve-outs we've been talking about are only to arrive at this total program general inpatient routine cost. Again, the keyword there being general as opposed to intensive care. And finally, we get to the latter part of D-1 Part 2. This is where those SNF and NF swing bed costs are actually reported. So these are flow numbers. These are calculated numbers based on the rates that you reported back in lines 17 through 20. But the point is, these amounts for the line 64 and 65, these are the SNF costs, the Medicare, the program SNF costs that are going to be allowable. If it's a critical access hospital, this amount flows to E-1 Part 2, whereas for the acute care hospital, they're paid on PPS, so this Medicare swing bed SNF cost really is only used for data purposes. It's not used for reimbursement. But down here when we get to the NF, the Title 5 or 19 NF days, these, again, were carved out of the allowable Medicare cost. Now, if you're looking at the Medicaid side of the cost report, because keep in mind there are some Title 19 worksheets, and Title 5 for that matter, in the Medicare cost report, it doesn't impact Medicare cost reimbursement other than the fact that we've carved all these costs out, but here are the specific amounts used for those programs. So now on to the more important parts of where do you get those rates to report on those lines. So let's talk about the swing bed SNF rates. Now again, these are Medicare. SNF is Medicare, and these are only used for the acute care hospitals. These are not used for the critical access hospitals because, again, critical access hospitals are reimbursed based on cost. Now, we have D-1 Part 2, lines 17 and 18 for the SNF rates, 17 being before 12/31, 18 being on or after 1/1 of that next year. So it's split at the calendar year. Now, if we take a look down here, these are going to be found, or the official source of where these are found is CMS Publication 15-1, Section 2231. Now, if you go to that section here in this screenshot, it actually gives you a little bit of an overview of what I've been saying up to this point. Prior to the establishment of the SNF PPS system, Medicare payment to swing bed hospitals for routine SNF-type services was based on the average rate per patient day. Now, again, that is still the case for the critical access hospital, but that's no longer the case for acute care hospitals because they're paid on PPS. So for the acutes, it says while those regional rates no longer serve to determine the actual payment, they are still used in carving out the costs of such services on the hospital cost report, and then that data is used for a lot of other rate setting purposes. So that's what I was getting at earlier. Now, if you continue on in section 2231, you'll see the breakout of the different regions, and you need to know what state you're in and what region that corresponds to determine what Medicare rate to pull in. When you continue on down that section 2231 on the CMS website, you'll see each year, and it starts with a really early year. You have to scroll all the way to the bottom to get the latest year. And you'll see Region 1, the swing bed rate is $306.33 for this calendar year. And then if you go down, you see some lower ones. Region 5, it's only $229.73. So again, putting in the proper rate is important for that proper carve-out. Now, we also have these Medicare swing bed SNF rates located on our WPS website. If you're just browsing through our cost report audit section, and separated out by topics. If you go to the cost report rates key issue or topic, the very bottom of that you'll see swing bed rates. However, I've also included the actual link to that here. Now, when you go to that swing bed rates link, you'll first of all see the different regions that we talked about a bit ago, and you'll see the swing bed nursing facility carve-outs. And this is broken down by calendar year. We're actually going to talk about these next. So there's a link for every calendar year. And you'll also see the swing bed skilled nursing facility SNF carve-out rates. That's what we've been talking about the past minute or so. So if you click on this link, you'll see the actual rates, and we'll see them in just a bit. And those are the same rates that we just saw here. We just pulled them from the CMS website. Now, as we saw, the rates for each region were slightly different. It's based on the cost data throughout that region, the payment data throughout that region. Furthermore, the update factors used for each region might slightly differ. That's just, again, due to the fact that cost differs. The inflation of each region's costs just differs. Inflation's not the exact same throughout the entire country. Now, the reason this is important is that this update factor that's kind of implied, I'm calling it an implied update factor. Now, if we took a look at a particular region and we looked at the calendar year rate for, let's say, 22 versus the calendar year rate for 23, we can identify that there was an imputed update factor, just what factor was used to generate that higher rate. That's the inflation factor. Now, the reason that update factor is important, even though it's not published anywhere, you can impute it. That same update factor is required to be used for the Medicaid NF rates. And I'll explain that when we get to those NF rates in just a bit. But I wanted to point out that the difference between 1 year and the next year for a given region's Medicare SNF rate, that update factor we need to calculate the Medicaid NF rates. Even though CMS publishes the Medicare SNF rates, they do not publish the Medicaid NF rates. In fact, these are calculated state by state. We at WPS have a link, have our website with each of the states that we service, each of the states that we have acute or critical access hospitals in, and we've calculated those rates by gathering data from the state. Now here I have two different citations for the different rules related to the calculation of these Medicaid NF rates. At the top I have the regulation at 42 CFR 413.53, And it talks about the swing bed carve out. Specifically, it says the cost per diem attributable to all non-Medicare swing bed days. Again, non-Medicare is the NF days, the nursing facility days. That's based on the average statewide Medicaid NF rate for the prior calendar year. So again, the average rate for the prior calendar year adjusted to approximate the average NF rate for the current calendar year. So keep that in mind, and let's go down to the policy that says essentially the same thing. This is found at CMS Pub 15-1, Section 2230.5, and it talks about payment to swing bed hospitals. So it says something very similar, but actually in a little more detail. For all non-Medicare swing bed days, the amount subtracted, or the amount carved out, is based on the average statewide rate paid for routine services in nursing facilities under the state Medicaid plan during the prior calendar year, trended forward to approximate the average NF rate for the current calendar year. Trended forward is another word for updated or inflated or adjusted. And the key word here is it's approximating the average NF rate for the current calendar year. So what this means, and this is never reconciled, it's never trued up once the actual current year rate is known. The rates are always estimates based on a prior year actual amount updated forward. So this is where the complexity comes from this. We always have to take actual data from a prior calendar year by going to the state, gathering that documentation, and we use that Medicare inflation factor, that imputed Medicare inflation factor, and we update that prior year to a current year. Again, it's never reconciled. It's not allowed to be reconciled. We have to use the prior year. So again, as a summary, the acute care and critical access swing bed NFs, the nursing facilities, use the prior year Medicaid rate for that state, updated by an imputed update factor, which was determined by taking the difference between the Medicare rates from one year to the next. How much did it update for the Medicare side? All of those nursing facility days are reimbursed under Medicaid or under some other plan, Medicaid Title 19 or Title 5, but they're not reimbursed under Medicare. That's the key thing there. And the important piece about this, and we get this question quite frequently, we've talked with CMS about this in the past, we can never use the actual current year rate, regardless of whether it's known or not at the time you file or at the time we final settle. We are always required to use the prior year actual rate trended forward to approximate the current year rate. It's not an interim rate that gets updated or gets reconciled. That is the final amount we're using. We're required to use that. Now, the other question here is, where can you find these swing bed NF rates for non-Medicare? Again, they're not found in any CMS policy manual. They are only found by going to the MAC, essentially, to gather those rates. So we have ours reported on our WPS website. And again, it's that same link from earlier. Specifically, if you click on the link that talked about the NF rates, it was listed out by calendar year. You'll see, first of all, before you get to the rates, you'll see a little bit of information helping you to identify where should this rate be reported. Again, it's split by calendar year, so if your particular cost reporting period is a non-calendar year, it's other than 12/31, then you would have to use two different rates for the two different lines. Specifically, it'll tell you, hey, if it's a 12/31 calendar year, then this is the only rate you need, and it gets reported only on line 19, nothing on line 20. But if you have a 6/31, for example, you'd report this rate on line 20, and then last year's rate on line 19, and then if it's a 6/30/22 the next year, essentially, then this rate is basically the prior year rate that gets, or the first half of the year's rate that gets reported on line 20, or line 19, and the next year, the 2022, would be reported on line 20. So now I just wanted to have a slide here talking about just how we develop those rates, those swing bed nursing facility rates that are non-Medicare. Every year we have to contact the various state agencies that we have any acute or critical access provider in. We have about 38 of the states across the nation, and we have to obtain from that state the average rate paid throughout that calendar year for the nursing facility services. And then we take that and we update it using the same update factor that was used or imputed for the Medicare SNF rates in that region. And it is region specific. That's the key thing. Now the complications about this. Sometimes you may go out to the website looking for this information. You may find it's a little delayed. Largely that relates to delays we have in getting data from each state. Now keep in mind, some of these states don't use a calendar year for their own rate setting. They may have their own state fiscal year. As such, we have to wait until both calendar years that we need, both state fiscal years that we need are available for this one calendar year. And then we have to prorate those two state fiscal years into one calendar year. So that might be 75% of one state fiscal year and 25% of the next, or it just depends on how the months fall out. We have to prorate them to figure out what that 12-month calendar year rate would have been. Another complication with this is that it's not always as easy as them just giving us one rate. A lot of times they'll give us a big listing of the different rates that were paid throughout the year, either by provider or by service type. Therefore, we have to average them out as the regulation and policy requires. It's an average rate paid throughout the year. So we have to identify that. We have to potentially prorate it into one calendar year. And then, of course, we have to calculate that imputed update factor and update it to give you the rate that's going to be used for your current year. In other words, this rate you see right here, it's labeled as 2021. This, for Alabama, for example, this $223.65, that would have been 2020's actual rate for the state, for the calendar year, updated by some sort of update factor. So in other words, this has already been updated for you to approximate a 2021 calendar year rate. Now also for that reason, however, because it's never reconciled, it's never really carried forward, so you may see a situation, now I'm just using Alabama as an example, for example, the 2022 Medicaid NF rate may possibly be less than this rate. It may be close to it, it may be quite a bit higher than it, even though the actual rates in that state haven't. It all depends on how the actual rates that year have changed, and then we have to update it to approximate the current year rate. So in other words, for 2022, to calculate that rate, we are not starting with this 223.65 and updating that forward. Instead, we would go to the state and find out what their actual 2021 paid rates were, which may or may not differ from this 223.65 approximate number, and we would update that actual rate forward to 2022 to approximate 2022's rate. That's the complexity with the policy and regulation behind this, the two policies, or the policy and the regulation we talked about a bit ago. Now the key thing, if you are filing this cost report before that year's NF rate is available, the only thing you can really do is use the prior year rate that was available, the last rate we've reported for that year. Once we take this to final settlement, we will plug in the proper rate that we've calculated or approximated. So it will be updated at final settlement. But again, you don't need to hold the cost report. You don't need to do anything like that. Sometimes these rates just aren't available. So that's really what I wanted to point out. So I thank you for your time. Hopefully this has helped to clarify some of the questions you may have had about these swing bed rates. I look forward to talking to you in our next session. Have a good one.